Are we on?
Not yet.
Okay.
Still going. You should be good.
All right. Good morning. Today is Friday, March 21st, 2025, and welcome to the Southern Maryland Delegation meeting. It is our final meeting, but a very important meeting, and we have special guests today, and you will hear information regarding our health system. But before beginning, please have Delegate Morgan, Todd Morgan, if you would offer the Pledge of Allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you so much, Delegate Morgan. Please bow our heads for a moment. Heavenly Father, as we gather here today, this morning, let us be thankful for so many people who are leading our nation. Leading our nation in terms of today, we're focusing on healthcare. Give them guidance, give them funding, give them strength. This and other names we pray. Amen. Okay. You notice I asked for funding because I believe that is a critical issue when we look at having a system where our constituents are afforded the best possible care. And we're really excited to have the three county health officers with us today to give us an update. They have organized their comments, and I'm going to introduce for Calvert County, Dr. Mora, Charles County, Dr. Diana Abney, and from St. Mary's County, Dr. Stephanie Harper. Ladies, welcome, and we look forward to hearing your information.
Good morning, Dr. Taneza Mora. It's a pleasure and an honor to be with all of you this morning. So we prepared a joint presentation actually, and so I will begin with the first part of the presentation, the critical role of local health departments in Southern Maryland, and then we'll hand it over to Dr. Harper and Dr. Abney. So in Southern Maryland, the local health departments play a very important role in providing multiple services that the main purpose and the main mission is to prevent illness and injury, and it's really to promote health for our community. Our local health departments work hard every day to create those conditions that allow each person in the community to achieve the best health that they can. And our staff work hard to educate the members of the community about health, important health topics, and so that they can choose and be well informed and make the correct choices to protect themselves and to maintain good health. So what you see here is a listing really of all the activities and the efforts that are put forward by the Southern Maryland local health departments.
Dr. Mora, I'm gonna interrupt. I apologize. You are not screen sharing yet.
Oh, I'm so sorry.
No problem.
Let's see.
But I know you have a beautiful presentation, so I want to make sure it's up.
Yes, that's right. So let me go ahead and I got a little ahead of it. So I'm going to go back. So this is really the main topics that we're going to cover today. And these are the services, multiple services that we offer through the health department. And I'll talk about them in a little bit more detail in the next few slides. But the main thing is all of our activities have one common mission, and that is to prevent illness and to promote population health. All of those activities that are in white font are activities that support the promotion of population health. But when there is a gap in the community in clinical services, then the health departments also step in and provide such services. So the yellow fonted bullet here are the clinical services that have shortage in workforce in Southern Maryland. So they are primary care as well as behavioral health. And I do want to make the distinction between population health and healthcare. So our local health departments are involved in promoting population health, and that is to build and to improve the health of the community as a whole. And that differs from healthcare, which is the provision of medical care to individuals in the community. And we do both. So we do more of the population health, but we do provide the healthcare or clinical services in areas that there are gaps. Okay, in the next slides, I will be talking about the core functions and services of the health departments. And on this one, it's really the provision or the detection of infectious disease and its control, as well as prevention. What you see here are the activities that support that core function. And it starts with collection of community health data. And so we use the community health data to understand what is normal and what are the normal information and normal rates in the community. And that allows us to immediately or rapidly detect what might be abnormal and what might be considered a health threat for the community. And as you probably already know, there are measles outbreaks in the Southwest, and just most recently in Maryland, as of today, there have been reports of total of 3 cases of measles, 1 in Howard County and 2 in the Prince George's County area. And these kinds of events really highlight the function of local health departments. So the local health departments in Southern Maryland are really gearing up and preparing, for those times when these cases might occur in our area. And so we prepare the community by putting out messaging to improve community awareness about measles and about the importance of vaccination as the most important and most effective way of preventing measles. We also work with our community partners, our healthcare providers, provide them guidance. We make ourselves available for consultation, and in case they have questions on testing, if they need support if we need to facilitate testing, as well as even obtaining, certain post-exposure prophylaxis for people who may have been exposed to measles. So I think something like these events really highlight the importance of that function of our local health departments. Another important function is the provision of environmental public health services. Food safety is a priority, and so our staff actually perform multiple functions to support that. An example of that would be the inspection of restaurants. So we inspect restaurants to make sure that the food is stored appropriately and that it's prepared and handled in manners that meet regulations by the state. We also perform inspections of pools to make sure the water is safe to be swimming in. In the rural areas, it's really the inspection and the permitting of water and well constructions and septic systems. And so we permit those systems that have to meet or that meet the criteria and regulations of the state and that pose a low risk. We absolutely want to minimize and reduce the risk to the community. The problem is if these septic systems fail, then some of those sewage could potentially leach into the groundwater as well as into the surface water and then pose a risk to the environment and the people. It could be at risk for being exposed to infectious diseases or to toxins. Another important function is really in terms of rabies control. So our staff are very active in this. They take actions to protect the community against rabies. So just an example, and this is probably true for all of the counties, but in our county, we see and receive over 200 reports of 200 reports of animal bites to humans each year. And so my staff works with animal control to make sure that the animals are appropriately handled. If they need to be quarantined, then my staff works with that. And then I have other staff that follows each of those individuals that sustain a bite to make sure that they receive the appropriate post-exposure prophylaxis, which is really a series of rabies vaccines that person has to complete to reduce and minimize the risk of getting rabies. So rabies is a viral disease, and once a person gets it, then there really is no treatment. It's very rare that they could survive that. So I call that a uniformly fatal disease. Next slide. So our staff are heavily involved, and our health departments are heavily involved in the promotion of health and distribution of health education materials. So we engage with the community to gain their trust and to allow them to work with us as well. And the local health departments provide multiple services, as you see there on the screen. And I'm just going to describe a few of them. We do offer screening for diseases that are referred to as silent diseases. So this is something like hypertension or diabetes, which don't have really any symptoms early in the disease. And so persons who may have them may not realize that they are afflicted with these conditions, but the screenings that are provided by the local health departments to the community allows those individuals to be linked to care early. And when they're linked to care early, we prevent the complications, of hypertension and diabetes. And the complications could be things like chronic kidney disease that could lead to kidney failure, eye disease, diabetic or hypertensive eye disease that could lead to blindness if they are not taken care of early, and then cardiovascular disease, that's heart disease, that could lead to heart attacks and even death. Other things provided by our staff are maternal and child health services. So we provide services for pregnant moms, education about tobacco use, substance use, and all those items or things that could pose a risk to them during that pregnancy. We also offer screening for the 4 most common causes of cancer deaths in the U.S. And they are colon cancer, lung cancer, breast cancer, and I would like to say prostate cancer too. So we are working on determining to see how we could deliver the screening for prostate cancer. And then we work with the schools. So tobacco use is quite prevalent. Vaping is quite prevalent among our high school students. So our staff work hard to provide services to the schools, do outreach to the schools, so students receive information about the potential risks and harms of tobacco use and vaping. And we do this quite consistently, and because tobacco use is the #1 cause of preventable death in the United States. And I would say that our local health departments are one of the few providers that give free tobacco cessation classes, both to adults and to youth. And on average, our program, each county, performs tobacco education outreach to over 4,500 students annually. And then there are years where there could be more also. And then for mental health wellness, as well as substance use prevention and violence prevention, we provide life skills curriculum that teach middle school students and high school students critical life skills, as well as coping skills, so they can exhibit resilience and maintain mental health wellness. So an important role that we have too is the involvement in emergency preparedness of our community. So we work regularly to make sure that our jurisdictions are prepared for public health emergencies, such as those that you see on the screen, pandemics, disease outbreaks, as well as natural disasters, chemical emergencies, or nuclear accidents that can impact the health of the community. And we do this by distributing health information to the residents, talking to community leaders, and advising them about how to prepare best for public health emergencies. We plan and we drill regularly with our local governments and the hospitals, as well as community partners, to make sure that we are ready, in case that these events occur. And we partner with the county, private partners, as well as community groups to identify resources that could be really helpful to community members in the event of these health emergencies. So, and then when health emergencies occur, then behavioral crisis emergencies could also occur. So our teams are consistently working with emergency medical services as well as law enforcement for a coordinated response to provide emotional support or emotional support for people who may be experiencing mental health crises during these events. Okay, and then as I mentioned earlier, most of the work that we do are involved in promoting population health, but in areas where there are shortages in clinical services, then the health departments step in and become the safety net and actually provide clinical services. So all Charles County, Calvert County, as well as St. Mary's counties are designated health professional shortage areas. And for those reasons, we do, there are places where we provide primary care services, and behavioral health services. Examples of this are the school-based health clinics in St. Mary's counties that provide primary care to students who may not have a primary care provider. They provide vaccinations, as well as sports physicals, sick appointments, and routine primary care appointments. In Calvert County, we don't have those services, but we don't have school-based clinics, but our staff do provide those services to the schools in a different form. And so we provide vaccinations to the kids in the beginning of a school year to prepare them for the school year. We also provide behavioral health services in the school. So we call those school-based therapies where we have.
I'm back.
Yes. I'm sorry. So yeah, and so we have local health. Yeah, we sponsor behavioral clinics. St. Mary's County and Charles County sponsor behavioral health clinics, and in Calvert County, we have embedded therapists and social workers in the schools to provide access to mental health services for the students. And I just wanted to report on one other thing. So we looked at the opioid-related deaths, the number of opioid-related deaths in Calvert County from years 2020 through 2024. And we have noticed a reduction. It's like a 40% reduction in the total number of opioid-related deaths. And we're still looking at the data, but we really believe that those services that we've implemented here have contributed in one form or another to that decrease and that good outcome. And those services include the crisis services, where our teams respond concurrently and in a coordinated way with EMS, as well as the law enforcement when there are mental health crises being experienced by individuals in the community. And then we have those school-based therapy. We have outpatient mental health clinics that make care for mental health services available, so it improves access for community members. And then there is outreach. And so the outreach to the community to inform them, increase their awareness about mental health. And then we also have efforts to push out Narcan training to the public so that they could recognize what an opioid overdose might look like and how to implement and administer Narcan. As you can see, our local health departments really provide a lot of services, and they are creating a positive impact in the community, and they are making a difference in many people's lives. So my portion has ended, and I'm going to turn it over to Dr. Harper.
Thank you, Dr. Mora. Good morning. I am Dr. Stephanie Harper, the Deputy Health Officer for St. Mary's County. And now that we've had a great description of what we do in public health, I'll discuss how we do it and what's in place to make public health happen. That begins with the Public Health Authority and the joint supervision of local public health that enables and supports the local public health department. Next slide, please. Are you able to? Oh, thank you. Part of our ability to be nimble and responsive comes from the way in which the health department is governed. In Maryland, local public health is structured as a hybrid entity. The local health department is led by the local health officer and is influenced by both state and local factors. There are state and local delegated authorities, state and local funding, and state and local supervision. On one side of the slide are the state influences, specifically the Secretary of Health at the Maryland Department of Health, the Secretary of the Environment at Maryland Department of Environment, and the governor, all of whom either delegate authority to the health department or can direct the work of the health department by executive order. On the other side of the slide is the local source of authority, namely the local governing body, which in Southern Maryland is the elected county commissioners who serve as the Board of Health. In this shared governance model, the health department is able to elect to use state or local processes based on which set of rules are the most flexible and responsive. So, for instance, with respect to procurement, that's done so that goods and services can be procured in the simplest and fastest way, which is critical in the time of an emergency. The shared model also provides the health officer with additional local authority to respond to specific issues, and it can provide access to opportunities for support of local projects that may not qualify for state attention. The result is that in Southern Maryland, the health departments offer similar services, but also provide some services that are fit for that specific community. Another way to look at it is that the state and local government both provide the health department with authority and resources, and this allows it to be flexible and respond in ways that best meet the needs of their communities. Next slide, please. With state and local authorities and state and local resources, public health exists to provide essential services, as you've heard. And as you can see by this diagram, there are a lot of services to provide. Depending on where you are in Southern Maryland, it may look different, as was already discussed. But whether it's diagnosing or investigating to combat causes of sickness and disease and disability, or informing and educating the public, or developing and championing policies, or enforcing laws, or linking community members to care and services, or monitoring health in the community, or equipping our public health workforce with the skills needed to meet the moment, or using data to evaluate, identify assets and needs, we are in the community doing the things required to help it to thrive. But even with a strong and capable public health workforce, we can't do it alone. Next slide, please. And because we can't do it alone, the local health department, Dr. Moore, I don't know if you're able to adjust that slide a bit. And because we can't do it alone, the local health department becomes the chief strategist for the community. And it is the work of the chief strategist that also helps keep the health department nimble and responsive. As the chief strategist, the health department performs community health assessments and community health improvement plans. To do this, we work with the community to get a comprehensive view of the community's assets, current health status, and risk factors for poor disease outcomes. That is called the community health assessment. Once that information is obtained, a strategy is developed and implemented to address critical health issues. That is the community health improvement plan. This process of assessing the community and then developing and implementing a plan to address identified issues is repeated at defined intervals, but is a continuous cycle of action that keeps the health department able to identify current community needs and respond by implementing interventions that are science-driven and data-based. Importantly, local health departments, while they routinely assess the health of the community, there may not be funding available to address needs identified in the assessment. Next slide, please. Another key to being the chief health strategist for a community and to remaining nimble and responsive is the ability to mobilize and deploy partnerships. The work of the Community Health Assessment and Community Health Improvement Plan requires the mobilization and deployment of partners around a shared vision. These partners come from the health sector, the academic sector, public safety, local businesses, non-governmental and governmental organizations. Next slide, please. But on a more granular level, it is these entities that you see here in our communities that form a system or a community network. And the chief health strategist's role is to cultivate this network and then to mobilize and deploy it to advance public health. The network certainly involves the public health agency, but it includes employers and faith-based institutions, law enforcement, schools, civic groups, primary care physicians, specialists, the transit authority, etc. A public health response may require everyone all at once or may not require everyone all at once. But when you need your partners, you want to have built a relationship such that they can buy into the shared goal and then deploy. It's the ability to build and establish trusted relationships with community partners that increases the flexibility of a health department and the depth of a public health response. Next slide, please. And this slide really is just here to represent public health in action. It shows examples of current Southern Maryland hot topics. Now, these are current topics, but I'm sure you realize that sort of behind all of this, the public health department and the public health system is still carrying on its routine duties. So these hot topics, may require sustained or intermittent responses. Some occur regularly and others rarely, but all require a nimble and responsive system. So whether it's respiratory illnesses, which happen about the same time every year and require us to educate on prevention and provide and partner to provide testing and vaccination as required, or whether it's community violence, which brings together local sheriffs and religious organizations and grantors maybe to provide safe locks, or whether it's a response to measles, recently resurgent in the United States, that's galvanized health departments internally to look at data, identify those most at risk, offer vaccination as appropriate, whether it's addressing substance use, which is a sustained public health issue, and the address of this can take many forms depending on which substance you're addressing. Whatever the response may be or require, the public health department has to be flexible and nimble enough to respond as needed. And that really is what our task in public health is. The system requires certainly funds, but it also requires a sufficient workforce that's trained and capable. One of the challenges for Southern Maryland is actually attracting and retaining workforce to do the work. Next slide. I think that's it. At any rate, thank you for your time.
Good morning. I'm Diana Abney, the Health Officer for Charles County Department of Health, and I'm going to talk to you a little bit about Health Department funding. As my colleagues have told you, we do a lot of things in the Health Department. For example, being, as Dr. Harper told you, the Chief Health Strategist, we protect our counties and our citizens from diseases. We educate them and empower them to have healthier lives. We develop plans to support individual and community health. We provide exercises not calisthenics, but exercises where we plan and play out what would happen in a public health emergency. We do those individually in our own health departments, and we also do those regionally and sometimes even statewide. So how are we able to do this? Well, funding is a big part of doing those things. Can you go to the next slide for me, Dr. Tenezamora? Thank you. So our funding comes from multiple sources. We have state and federal pass-through funds, which we call our core. That's a categorical type of funding, and it has identified measures that we must meet. And this is probably our most restrictive type of funding. We also have and we have state core, which supports some of our basic fundings and the fundings that fill gaps. If you'll notice, there's a list there. That is not an exhaustive list of what we use our state core funding for. And some of them have asterisks. I'm going to read the list, but those that have asterisks are just some of the things that we use it for in Charles County, in the Charles County Department of Health, such as general administration, infectious disease and epidemiology, which everybody has to do in health departments, environmental health, public health nursing, and down at the bottom, dental. Some other things that people may use it for is child and school health and maternity and child planning. And as I said, this is by no means an exhaustive list, but this is just some of the examples of what we use our state core funding for. Different jurisdictions face very many different public health challenges, and so they may use their categorical grants and their state funds and even some for different things that are unique to that county. Next slide, please. We do have some funds that are more flexible. Our local core funds, which are support basic function and fill gaps. And these come from our local county. And they are required match to our state core funds. There's a percentage that every county gives to their health department based on what their state core is. And those percentages vary between counties. There's a formula that they use to make them. And it is required that they give them. And this is part of what we use. And you'll see in a minute in my graphs how those things relate to each other. The different parts of our grant relate to each other. Grants and our fundings relate to each other. Then there's other grants, things that come from like a foundation, from CDC, from SAMHSA, MCHRC, sometimes health plans. And some of our grants that come from foundations can be very small foundations or they can be large foundations, but all of them help us provide the work that we do in the counties. These are also usually for specific projects, but sometimes these are flexible and we can use for other things or use across the board. Many of the health departments have fee-for-service funding. These usually come either from clinical services, permits, or certificates. For example, our dental program at Charles County is fee-for-service. So those are funds that we can use not just for dental, but as part of our overall funding. The only problem is that that's a small percentage of funding, and many health departments have very few fee-for-service programs. Then there's also collaborations with other agencies or other entities, and these are usually specific programs, but sometimes those are also flexible funds. Next slide, please. This is the chart the graph chart I was telling you about, and I used two examples of two health departments in the region. And if you look at the one on the left, for both of them actually, the green is grant funds. So a very large portion of our funding comes from grants. The orange is state core. The dark blue is local county funding. And the light blue is fee-for-service. And you can see when you look at these two different counties that there's a difference in how they do it or how they are funded in the different areas. For example, the one on the left probably has either more fee-for-service programs. They may have dental, they may also have behavioral health. The other one probably has fewer of those or fewer population that it serves for those things. But at any rate, all of these things together make up the funding that a health department has. And this looks different for every health department across the state. So now we're going to talk about, next slide, please. What's the impact of underfunding on our health departments? One of them is difficulty in managing disease outbreaks. And I'm not talking about a pandemic. A pandemic outbreak, as we all know from going through COVID, actually comes with extra funding. And so there's not as much of a strain on the health department. But when you have small outbreaks in your community, you put a strain on the amount of time that you have to pay nurses for overtime and staff and those kind of things, and supplies that you use. So with lower funding, you have difficulty meeting the needs of your county should there be an outbreak or a public health emergency. It also gives us reduced access to our community for our essential services, for things like education, for things like preparing the community to respond to things, for things like the next one, which is exacerbation of health disparities. We have reduction of time and money to decrease health disparities, to serve people who are less well equipped to meet some of the potential health emergencies that may come, or less well positioned to actually fight off some of the diseases that we know that we can help them do. And that's one of the impacts of poor funding or underfunding. And then there's, very importantly, a reduced ability to prepare and respond to public health emergencies. The reason that, and I like to think that we did a good job with COVID here in the Southern Maryland region, but the reason that we did a good job is because we do exercises, we train, we prepare for public health emergencies. So not having good funding and not having the ability to access funding would decrease our ability to keep our staff prepared for the next public health emergency, and indeed to keep them prepared to just respond to everyday things that public health people respond to. And then the last one, which is extremely important, difficulty in recruiting and retaining staff. Public health is not one of the places where people say, I'm going to go because I'm going to make a lot of money. They do it because it's something that they feel is a calling, that they want to help their community. They want to save lives. They want to make a difference in people's lives. So if we lose funding and or decrease funding, and we're already having people who are doing this for the good of the community, and we have less and less to offer them, less benefits, less money, less things that will make them want to enjoy their job, then it's more difficult to recruit staff, and it's not very easy to fill our positions as it is. And it also makes it more difficult to retain our staff. So these are just some of the big things that are a problem of underfunding in public health. So that's why we wanted to talk to you about funding. That's the end of my slides. I guess we're open for questions now.
Well, yes, we are. Well, first of all, let me thank the three of you for a very informative presentation, and also for the slides. We have forwarded the information to the members of the delegation, and we certainly appreciate, again, the comprehensive reporting that you have afforded us. So I'm not sure if we have any questions, but I do have a few. And Kara, you can let me know when we have questions. The first is about the clinics, the school-based clinics. How are they funded? Are they funded as a budget item for each county, or is there extra funding from the local governments?
So I'll start with that. I think Dr. Harper can give you even better explanation. We are just building our first school-based health clinic in Charles County. We had groundbreaking about a week or so ago at the Indian Head Elementary School.
Oh, that's right.
Yes. And so we have grant funding to get it started. And we probably will have to rely on grant funding for some time. We will be able to bill students' insurance companies for their care that they get, but I don't have the full details on how most school-based health clinics retain or continue their services. But to start out, I'm pretty sure that most of them start out with grant funding or donations. Dr. Harper, since you guys have been in the business for a while, perhaps you can tell them how they sustain them.
Yeah, so we do have two school-based health centers, and funding is grant funded, as Dr. Abney said. It does generate revenue once you sort of get that system in place and refined. But our local government has been a big supporter of that effort too. I mean, a very big supporter. So we've got three funding sources now. There is I'm sort of new to this position, but there's a state, I believe, office for school-based health centers. Is that correct, Dr. Dabney? And I don't know what support they can have, but I know that those grants and our localities and revenue generation, which we anticipate will get, we'll get better and better at it. Those are supporting our efforts.
My other question has to do with the communities. Is the information given out, are they all, is it bilingual, both English and Spanish?
When you say the information, you mean when people are working in the the school-based health center?
For example, if there are notices about, let's say, measles, vaccines, or any other community outreach, is it offered in both English and Spanish?
Generally speaking, yes, because Spanish is probably the second most common language in the state of Maryland. So
Right.
yes, and in fact, I don't know about my colleagues, but I actually have in the Charles County Health Department, we actually have a person who is hired on our staff to do interpretation in Spanish and to translate our documents into Spanish.
Okay, that's great.
Yes, we too have actually three certified interpreters, so we have that ability for Spanish too. And a lot of the information that, or not a lot, but certainly a significant portion of information that health departments have access to can be found in multiple languages, so even more than in Spanish.
Okay.
Already prepared.
And Dr. Harper, correct me if I'm wrong, but I also think that MDH can help provide languages that we can't find. I think they can translate documents and things into multiple languages if we don't have access to them ourselves.
Yes, and there's you can pay to have it performed, translations performed, etc. So there's a way to get it done when you need to have it done.
And I didn't say this when we were talking about interpreting. If you don't have a person, or if you have a language that is not very common, you also have access to what's called the language line. It's not quite as good as having a person, but you do get the person, someone to interpret in that person's native tongue, and they say exactly what you say and exactly what the person says back. So even if it's a language that we don't have interpreters for normally in our health department, we have access to a different means of talking to people in their native language.
That's great. Kara, do we have any questions?
I do not see any hands up.
All right, lastly, Dr. Mora?
Yes, ma'am. I really just wanted to say that in Calvert County, we do have translated materials that we distribute out as well. And we have bilingual staff, our community health workers. We have two who are able to do some translation and interpretation. But thank you for the question.
Well, thank you. Lastly, I have just a comment, well, a question. I serve on Ways and Means, and each year we have students coming in with requests for legislation, etc. This year we had a request from students to be allowed to administer Narcan, to have it or to carry it or whatever. I don't think the legislation moved, but do you have any thoughts, yes or no, regarding students having Narcan? Or if you prefer not to answer, that's quite all right as well.
So, ma'am, I'd like to.
And I'll follow her.
Yes. So, I mean, Narcan has been effective, but they have to be appropriately trained. I think that would be the key. And we do have those outreach. We do have this outreach that allows people in the public to have access to that and training for Narcan, but it really hasn't been pushed into schools in the way perhaps this legislation is kind of being recommended. Anyway, but I think it would be helpful if students had the ability to use that. But the most important thing is that they have to be trained appropriately, and so they could save a life.
Absolutely.
So my point is exactly the same. In fact, before I had staff that did training of Narcan training, I trained children whose parents or whose family members had substance use or opiate use disorder. And indeed, if someone knows how to do it and can follow the instructions, there's no reason not to train them. It would be wonderful, I think, also to have it in schools, because the children in school know who's the substance users, and they are more likely to be close to them than the teacher or the athletic trainer who has Narcan and can bring it to them. So it'd be great if they could give a dose, send someone else to get the responsible adult so that they could save a life, and we may have a chance to get that person into treatment and make them or help them become not a substance user, but get into recovery. So I actually think that we should train them. And as
Well,
Dr. Tanez Zamora said, they do need to be trained themselves to use Narcan properly.
Well, thank you so very, very much. This has been very robust, very informative. And again, thank you for this. And we are certainly aware of the critical need for funding of your department as well as other health issues. So again, thank you for being with us this morning. And we know that you're always available for further questions. And I look forward to having continued partnerships with you, Dr. Abney, in Charles County.
Thank you so much. And thank you for having all three of us. We really appreciate the opportunity to talk to you.
Okay.
Thank you.
We will now move on to the Department of Legislative Services. This is a department I rely on a lot. All of us in the legislature do, because they do outstanding work and reference work for the entire state and nation. So I'm going to ask if I'm not sure who's representing the Department of Legislative Services, but you can please start. Mr. Birch, are you the rep?
Right.
Thank
So
you.
with me today is we're glad to be here with you to present the state aid information. Arnold Ajag, which is one of our state aid analysts, he's going to share the screen and present one of the reports with you. And also with me is Ms. Valerie Monroe. She's also one of our fiscal analysts. And at the end of the presentation, she's going to show you how to access the information on our webpage. So I'm going to start off showing you some slides from our state aid presentation. We prepare this report each year. I'm basically going to be showing you some exhibits that's based on the governor's plan. As you probably know, yesterday, the Appropriations Committee has reported out their assessment on the governor's budget. And I will kind of highlight some of the few changes that has been made. But if we turn to page 2 of the report, it kind of gives you a snapshot of what's included in the state budget for local governments. And it's around $11.4 billion. And as you can see, most of the state aid that's provided to local governments goes to the public school system. And if we turn to page 4, it kind of breaks down the state aid funding by each jurisdiction. And you can see that Calvert County is expected to receive around $145 million in state funds. Charles County state aid is around $326 million, and St. Mary's County is around $184 million. You can see to the right, we put it on a per capita basis and on an annual change basis. What's important to note that around 70% of state aid to local governments is based on local wealth, and local wealth is measured by a jurisdiction's property tax base and net taxable income. And the purpose behind this is to provide jurisdictions that have a lower tax base with more state resources. So you can see that the amount of state aid that's provided to local government varies to around $1,000 per capita in Talbot and Kent County on the Eastern Shore to over $3,000 per capita in Baltimore City and Caroline County. If we turn to page 7, it kind of breaks down the funding by unit of local government. As stated earlier, the vast majority of state aid is provided to the public school system. So here you can see for each jurisdiction how much will go to the county government, how much will go to the community colleges, the public school system, libraries, and also the health departments, which we had a presentation on earlier today. You can see here, based on the governor's plan, the Calvert County local health department will get around $3.5 million. Charles County would get around $5.4 million, and St. Mary's County would get around $4.1 million. Page 10 of the report kind of shows you the projected annual change on a percent basis from year to year, and overall state aid is projected to go up by 5.6%. Now, what's important to note for Calvert County was that I think you all were aware of what happened last year with their personal property tax base. The system went from a pilot to a tax credit, and that impacted their wealth calculation. So their state aid for their public schools actually decreased in FY25, but for FY26, the wealth situation has been corrected since the county has gone back to a pilot instead of a tax credit. And so now they are receiving the full funding under the education funding programs. We're going to shift our gear, just go over some highlights on some major programs. If you turn to page 22, it kind of shows you the funding that's provided under the police aid formula. And then page 23 shows you the allocation of how the funds are allocated. For most jurisdictions, the funding is based on population density. More urban jurisdictions receive a higher per capita funding amount. Page 24 shows you the additional funding that's provided under the Police Aid Enhancement Program. And you can see here funding is allocated based on total violent crime offenses. Page 29 shows you the county by county allocations for the local health grants over the last 5 years. Then let's turn to page 30, which will give you a summary on how local highway user revenues are allocated. What's important to note that in FY28, the highway user revenues are projected to revert back to funding levels in FY24. So that is something to kind of look out for in the near future. Page 33 shows you the allocation of the local highway user revenues for FY26 for the county governments and for the municipal governments. Both the county and municipal share is based on vehicle registration and road mileage in each jurisdiction. We are now going to spend the next couple of minutes going over education funding. If you turn to page 41 of the report, it kind of shows you the total state aid allocations to the public school systems, and it also shows it on a per capita basis. As we stated earlier, the vast majority of state aid to public schools is based on local wealth and student enrollment. Page 42 kind of breaks down the state aid for both direct aid and for teachers' retirement. What's important to note that direct aid is based on local wealth, but the per pupil retirement numbers is not wealth adjusted. It's just based on the teacher salary base and the number of teachers each local school system have. On page 43, kind of shows you the increase in direct aid and total education aid on a per pupil basis. You can see that for direct aid statewide is going up by 6.1%. Charles County's aid is basically flat, and Somerset County's aid is going up by 4%. Page 45 kind of shows you funding under the foundation program. This is the basic education aid program that provides nearly $4 billion to local school systems. This is basically based on student enrollment for full-time equivalent students and on local wealth. Page 46 provides you information on state education funding under the Blueprint initiatives. And then page 47 provides you information on state education funding based on our targeted student populations. Compensatory aid funding is based on the free and reduced price meal count. We have our English language learners program that provides additional funding for English language learners and our special education program. I'm going to kind of probably stop our presentation right now, but just to highlight on pages 50 through 55, it provides you with information on local wealth. And on pages 56 through 62 provides information on student enrollment. If we turn back to page 11, it kind of highlights the governor's proposal, his proposed reductions to local funding. And as I stated earlier, the Appropriations Committee has already reported out their plan, and their plan does make a few changes. So one of the major changes in the appropriations plan is to reject a reduction for collaborative learning. So those funds will remain in the state budget. And if you turn to page 12, and let's go to page 13, it kind of shows you on a county by county basis the reductions that has been rejected by the Appropriations Committee. The Appropriations Committee did approve the reductions, if you go to page 14, for the property assessments. So the local governments will have to take on a higher amount of the property assessments cost, around 90%. Currently, they're paying 50%. And also the governor's, the Appropriations Committee also approved the remaining proposed local cost shifts as well. So I'm going to stop it there and open it up for questions. And if we do have time, I would like for Ms. Monroe to kind of show you on our website where you can access these reports.
Well, Mr. Birch, thank you very, very much. This is a lot of information, but it's very timely as we contemplate the final adoption of the budget. I know in Ways and Means we had a hearing overview on yesterday as well. Kara, can you advise me if we have any questions?
No questions, ma'am.
Before you close out, I also, and Ms. Monroe, we want you to give us the information. But I want to tell you personally, of the Department of Legislative Services, how much I personally appreciate what you do. At the end of the session, the 90-day report is like the Bible. I just tell people this is the Bible that what we did over the session. So it is utilized and appreciated so very, very much. So, Ms. Monroe, will you come on and tell us, the audience, where we can find your information?
Thank you again, Delegate Patterson. So I would just like to give you a quick walkthrough of how you can access some of our local government resources. So starting from the Maryland General Assembly website, you select, can you see my screen?
Yes.
Okay. Sorry about that. Yes, so starting from the Maryland General Assembly website, you select the Legislative Services tabs, which is right on the top right-hand side of the screen. And this takes you to the Department of Legislative Services website. So to access the state aid reports, you select the Budget tab here, and then you select the State Aid to Local Governments tab. And here you can find all of our state aid resources. I want to just draw your attention quickly to the 2-year charts by program. And this presents the information to you for fiscal 25 and fiscal 26 by area and by program. And you can also access this information for the state and for each jurisdiction. So in the case of Southern Maryland, if you would like to narrow your search down to Calvert County, Charles, or St. Mary's, you just go to the left-hand side of the tab and you'll be able to access those reports. The other report I would like to show you quickly is the state aid report, which Hiram just presented to you. And what is also important to note is that the information on this page currently reflects the governor's budget as introduced. And as Hiram mentioned, this information is going to be updated to show the legislative appropriations very shortly. I just want to show you quickly how you can access some of our other local government reports. And to do so, you must select the policy areas tab because it's located on another section of our webpage. And then you go to the intergovernmental tab. And here you can find a wealth of local government resources. At the bottom of the page, you can find our annual reports here, but I just want to draw your attention quickly to the local government, to the County Revenue Outlook report. And this report provides a snapshot of the fiscal health of county governments in Maryland for fiscal 23 through 25. And it's a really great resource to also look at in conjunction with the state aid overview report. Another very important report I want to bring to your attention is a local government overview report. And this report also has a lot of valuable and useful information on local government finances, local tax rate, local revenue growth, and we also included public school funding, and we presented on a per pupil basis for local, federal, and state. So again, I want to thank you I know it was very brief, but if you have any questions, we're here to assist you. Please feel free to reach out to us. So thank you again for the opportunity to present.
Well, really, I want to thank you. Thank you so very, very much. Again, we appreciate it. And again, the information has been shared with our local delegation as well. If there are no other questions, I want to say this is our last delegation meeting for the session. It was a very compact but informative one. And I want to thank you again for being here. I want to thank my colleagues for being here today and for all the meetings that we've had, and certainly the staff, my Chief of Staff, Kara Franklin, and all the other Chief of Staffs for the various Senate and delegate officers. Thank you for your cooperation and your attendance. And for the public, thank you very much for your engagement. We wish you well, and again, have a very blessed